Good day. I'm back again, your host, with the most information about nurses. Today we continue again on part two of the interview tips to look into various aspects of the interview. Earlier on part one, we talked about the introduction, how you prepare yourself for an interview. Now we'll continue without wasting much of your time. One of the questions that can be asked in an interview is to tell us about hypovolemic shock and its management. As you know that there are different types, reasons why a person can lose fluids from the system, from the body. It could be as a result of bleeding, internal or external bleeding. It could be as a result, it might be medication itself, like the diuretics. It can be also burns if the patient sustains a significant amount of burns that can lead to bleeding. It could be just a condition, anemia. Patient could be having anemia. So you need to understand the cause for hypovolemia, and then that's how best you can tackle it and be able to treat the condition. Okay, so we'll move on and look into other aspects that you need to be cognizant about, like iNews. You can be asked, tell us about iNews score. What do you understand by iNews score? And when the score is 7, what does it mean? So in this case, you need to understand the iNews chart. So you need to Google it, download it, go through the iNews chart, what it is about, and also understand the A, B, C, D, E. On the left side of the iNews, A for airway, then you'll be looking into the airway, and the B for breathing, you're looking into the breathing. It goes on like that. But when it comes to an abnormality of these vital observations, and then that's when you have to do what we call escalation protocol. So you have to follow the escalation protocol. When the iNews 7, it means that's an emergency, and you need to inform your nurse in charge or your CNM, your clinical nurse manager, and also you need to escalate it immediately and inform the SHO or the consultant to come and review the patient immediately, because it is an emergency and we do not want to delay management of the patient in this case. As well, what you need also to do is to do an ISBA communication, to fill up an ISBA chat or an ISBA 2 and attach it to the notes of the patient to know that or to make sure that you have done your part and you have communicated with the doctor to come and see the patient immediately. And you need to understand also what ISBA is. ISBA is basically a communication tool that is used when a patient is deteriorating. So it is used in a deteriorating patient to communicate to the doctor to come and review the patient. Right. So we'll continue also to look into the other aspects, and you can be asking a question: what does working within your scope of practice mean? Right. So you need to understand you're a professional, somebody, and you have ethics, and that guides you. Right. Code of ethics that guides you in your professionalism or in your work environment. There are things that you should not do, there are boundaries you should not cross. And you have to do this within the permissible laws of that country. So it's something that you have to do according to the knowledge that you've acquired during your nurse training. And it is to be acceptable in accordance to the practices of that country, the laws of that country. Right, so we move on, and you can also be asked a question like, what happens if a doctor calls to give you a prescription over the phone? What do? Can you take a prescription over the phone? The answer is no. You cannot take a prescription over the phone. The doctor should come and write the prescription. So it is not allowed to take a prescription over the phone. The doctor should rather come, really come and write the prescription. So we cannot take orders, especially to manage a patient on a certain, or to commence a patient on a certain medication over the directives, over the phone directives rather. Yeah. And then if a patient is deteriorating, what actions will you take? If there are no nurse or a doctor present, what will you do? All right. What will you do if a patient is deteriorating and there are no other nurses around and there is no doctor? What do you do? That's the early warning score, the Irish early national score. We talked about the INUs and what we need to do. So you don't leave the patient unattended to. And yes, communication has to be done to the relevant authorities, and you need to call for help, right? And you need to be with the patient, make sure that the patient is comfortable. But that's an emergency. You need to alert the responsible authorities. You need to alert your nurse in charge. You need to alert if there's no nurse, like has been said, you need to inform the doctor to come immediately and review the patient. But what you need to do whilst you are with the patient is to do A, B, C. Check the airway of the patient, the breathing of the patient, the circulation of the patient. If the patient loses consciousness, of course, in this case, you're doing also the GCS, the Glasgow Coma Scale, you're monitoring the neurological observations of the patient. Is the patient still conscious? If the patient loses consciousness, you need to commence, or if the patient is lost the pulse, you need to commence CPR, cardiopulmonary resuscitation on this patient. So if there's no more pulse on this patient, you need to commence CPR, and you need to call for help as well, like I said. And we need to have also the AED in case that we might want to resuscitate the patient using, some electrical impulses being injected into the system to resuscitate the patient. And also, what would you do if a patient complained that they did not receive their medication in the morning? How would you ensure that the patient's safety is taken care of? There's so many instances whereby you find that the drug cardex has not been signed for, or there could be many reasons for the missing signature in the cardex. It might mean that the drug has not been given completely, or the drug has been given and the staff nurse forgot to sign. Or the patient can say, I did not receive this medication, and yet the medication is signed for in the drug cardex. What do you do under those circumstances? So, well, if that is the case, you need to communicate with the nurse in charge to alert the developments, to alert him or her the developments. And also, if the nurse who gave the medication is around, or even still at home, that has to be confirmed. So we need to confirm with the nurse that gave the medication or was doing the drug round to ascertain the disparities, to make sure that we are doing the right thing. We're not overdosing the patient by giving another dose. Because if it is information coming from the patient, it could be subjective information or data that has to be verified, because other patients might be confused and might tell you something that is not really the actual on the ground. But as you know, what is not signed for is not considered as given. So it is very critical. If there is no signature done on the drug cardex, we need to find out why. And What is the first thing to check if an elderly patient is admitted to uh, medical surgical from emergency? So if a patient is admitted from the medical surgical, what is it that you need to do? What assessments do you need to do? First of all, you need to find out if the patient has not sustained some sores, because some pressure sores, because they'll be like on a stretcher or on a stretcher for long hours in the emergency department there. So make sure that you assess the patient as you're taking the history of the patient. Of course, you need also to do some vital observations. So head to toe examination is very critical when a patient is coming from a medical emergency department, to certain that there are no abnormalities and they are not admitting a patient who is already has been affected during the time he or she was at the emergency department. So you need to assess the patient, do your observations as usual, take history of the patient. And you, by so doing, you get to understand more about the patient, the needs of the patient. How would you recognize and manage a patient who suddenly deteriorated after surgery on your ward? Okay, and then the patient might then have, a patient who has just come from a surgical intervention, is deteriorating in the ward. What do you do? And the blood pressure is getting low and has clammy skin. Certainly, you could suspect bleeding. You might not see the bleeding from outside. It could be internal bleeding. Definitely, you need to inform the surgical team, inform your nurse in charge of the new developments, and escalate to the surgical team to come and review the patient. They might need to take the patient back to theater for examination, or for correcting the anomaly if there is bleeding on the patient. Right. The next thing that we can talk about: 3 patients come from ED to your ward. What do you do? So you have 3 patients who are actually equally sick, all different conditions and different stage of sickness. What do you do? Do you take care of the 3 of them? This question basically is trying to find out your ability to delegate. Will you be able to attend to all the patients? Because admission process takes time. You cannot attend to all of them, the 3 of them. So you need to be able to delegate. And you, as the senior staff nurse, your role in the interview is the senior staff nurse. You are asked your responsibility. What would you do under the circumstances when you face a situation? In this situation, you have to take responsibility on the most sick patient and be able to delegate the rest of the patients to others. All right. Where are we? Okay, student nurse monitoring. How to teach a student nurse on the first week of work. So you're working and assigned a student nurse in the ward. How would you work with a student nurse? Well, first of all, you need to determine the level of education of the student nurse, what she knows or what he knows, and definitely has to work under supervision. This particular student nurse is a novice in the field and inexperienced, so would really need guidance through and through, supervision through and through, and encourage the student to ask questions, and create an environment that is so free and for the student to learn and to be able to ask questions that are relevant, or that nothing is silly. Whatever question the student can ask, you need to be able to answer that. And then let's look at falls and pressure ulcers, how to treat. So how do you treat falls and pressure ulcers? These are 2 things that you need to really look into. Let's talk about falls. How do you treat falls? Well, the best way of treating is to prevent. So we need to prevent the possibilities of a patient falling. First of all, you need to look at the age of the patient. look at the fragility of the patient. Does the patient use an assist aid or a device or a frame or a stick? And if the patient is using any device, would always need assistance. So you need to assess the condition of the patient. Does the patient on medication that causes drowsiness and that can make them fall? And how's the BP? Is the patient on GTN? The GTN can cause drowsiness, or postural hypotension the patient can result into some falls. And let's look also into the general condition of the patient. Is the patient very sick, though mobilizing, and the frequency to go, or the need to go to the toilet? Do we need to provide a commode, or we need the patient needs to go to the toilet really? So if the patient wants to go to the toilet, we need to supervise and monitor and be with the patient all the time. And let's look at the environment in general. Are they clutters, or anything that can trip and make the patient fall? The shoe sizes as well, the shoe type, the shoes okay for the patient to mobilize using? Are they too heavy? Are they light enough to take the patient from point A to B? Let's also look into other aspects that are very critical when it comes to making sure that the patient is not falling. And it's very, very important that we consider also the floor, is the floor words and stuff like that. And also when the patient is in bed, is the patient able to come out of the bed or to jump out of the bed, resulting into a fall? And also, is the patient having the history of falling before? If those are the things that we need to consider. Now let's look at the other aspect of the question: pressure ulcers. How do you manage pressure ulcers? Different ways of managing pressure ulcers. Like I said, the best way to prevent ulcers is to treat ulcers, or treat a condition is to prevent. Prevention is better than cure. So pressure ulcers can be managed so many different ways. We have got what we call water law. It's also an assessment tool to determine the risk of developing pressure ulcers of a patient. And also what we need to look into is the age of the patient, the weight of the patient, the BMI, body mass index of the patient, the condition of the patient. Does this make the patient prone to developing pressure ulcers? And if the patient is bedridden, that can be really a cause for concern, and the need to continuously observe the bony prominent areas and be able to attend to their creams that can be applied when the skin is red and blanching, or when the skin is red, or when there's breakage of skin, and the different creams and sprays that can be given to the patient, and some tents, and to ease pressure on the areas that are at danger of developing pressure ulcers. All right, so these are some of the things that we need to look into. So for management of pressure ulcers, we have what we call a skin bundle. S for the skin, looking into the skin, and they can engage skin specialists. But before the skin bundle, what is your role as an S? Like we say, do you do 2-hourly turns or regular turns on the patient, and the other stuff that I've said? So on skin bundle, being a tool that is used to manage and treat pressure ulcers. As for the skin, there is also skin specialists who can look into the skin of the patient. Then the other S is for, so that's S skin, yeah. Then we have also, so we have the skin, we have the mattresses as well, upon which the patient sleeps on. They're very critical. So we need to determine that the patient has proper mattress upon which she or she sleeps on to avoid the development of pressure ulcers, the different pressure matrices that you also need to understand. And the patient has to keep moving, and you can engage the services of physiotherapist there. And incontinent, the patient could be incontinent. That can cause, sorry, for keep moving, the patient, if the patient is not mobilizing, not moving, that can really make them prone to developing pressure ulcers. So let's look into I for incontinence. Incontinence, that's where the patient is having bowels and the bladder uncontrollably opening. So we need also to make sure that we take care of that patient, changing the pads regularly, checking the pads regularly, and also be able to engage the services of the incontinence nurse. So these are the multidisciplinary teams that you work with. And we can also look into N for nutrition. So the patient need to have nutrition. The nutrition status of the patient has to be looked into and be able to make sure that patient receives high protein, high calorie diet to help the skin improvement and to help the bones and to generally help the healing process to take place. So we can also engage the services of a dietitian or a nutritionist in this case. So in a nutshell, that's what a skin bundle is about. So yeah, let's move on. Now let's look into routine day as a medical surgical nurse. What's your routine day? I think I talked about in part one, basically your routine day, what you do when you get to work. The first thing that you do is to get a handover. After getting a handover, you interact with the patients, you sit them up to prepare them for breakfast, and you also do medication round, drug round, give your patients some medications, and then thereafter you wash the patients. You also do drug round with the doctor. You also be able to do some observations on the patients, carry out the doctor's orders in the afternoon, and continue to work with the multidisciplinary team that are supposed to see the patient or that will have been referred by the doctor of the patient so that they get specialized care. So, and you continue to update your nursing care plan. So basically that's your routine as a medical surgical nurse. Washout complaint from relative. How do you deal with this situation? Washout is where a relative comes into the ward complaining or actually screaming at you for something he or she is not happy about. And how do you do that? How do you treat that situation? Well, what you need to do is to take the relative into a private room, ask and apologize, ask nicely, introduce yourself. My name is Lavas, I'm the staff nurse. May I kindly have a conversation with you in a private area and let me hear your concerns? And you take the person into the room. Also, you might need to carry the notes of the patient so that you know what to talk about, what are the issues you'll be referring to. What you need to do is to sit down in the private room there, and what your role is to do active listening, and listen a lot. Don't talk a lot, don't talk much. Give the client a time to speak, to air out and voice out the concerns. And you apologize despite the fact that it's you or not. You have to apologize and get to the bottom and assure the client that you'll be able to get to the bottom of the issue and be able to address it in a way. And if she is not satisfied by your answer, you still have to give her or him room to take it further to the next level or of grievance procedure at your hospital. And you have also to document that experience and inform your nurse in charge of what will have transpired. And the next one, what is the role of a medical surgical nurse? We talked about that. Discharge procedure and advices. Okay, let's talk about the discharge procedures and advices. Of course, the discharge of the patient starts from the day the patient is admitted into the hospital, right? So you cannot start the discharge of the patient when the patient is completely healed, because the whole purpose of admitting a patient into the hospital is to make sure that they are discharged back into the community or back to where they're supposed to be in a better state of condition. So the discharge plan and procedure starts on the day of admission. And when the patient is discharged, there are a lot of things that takes place. The documentation, the doctor has to write a prescription for the patient, discharge summary, some referrals have to be done, and also health education of the patient to the patient is key, and alerting them that they are going to be discharged, and also involve the relatives in the discharge of the patient. And everyone has to be on board on the discharge when the patient is being discharged, and educate on the drugs the patient will be taking home and to use, and other relevant multidisciplinary team that needs to be visited that should be informed as well. So that's what we can say about the discharge. And also the appointment dates have to be so clear, and the GP of the patient also needs to be involved. Is to be aware that the patient, his or her patient, has been discharged from the hospital. So, and there has to be some follow-ups from various authorities around the patient. Okay, and have you introduced anything new to your organization? Wow, that's quite an interesting question. Have you ever introduced something new into your organization? You have to show some creativeness. If you haven't, well, still be creative of something that you can introduce. You have to think critically as a nurse, because being a nurse, you're a critical thinker. I'll give you an example of something that I would say personally in an interview, in a typical interview scenario. You don't have to follow this anyway, because everyone who will be listening to this will be using that example, and that will be weird. So the fact that I'm going to say it, it means you're not going to use it. Okay, so what I would probably think of personally is introducing technology, because we're living in a world whereby everything is going online, is going the other way. Excuse me. Everything is going the other way. People are now engaging into technology, paperless environment. So I understand that most of the hospitals are still using the paper-based system, and that's really a lot of work to do. But I can introduce a system whereby, or I introduced where I was working, the hospital I was working, and a digital based system whereby you have to enter the patient in the computer, and every detail of the patient comes out. So you have like a code for each and every patient, or a company number, hospital number. You just enter that, and the details of the patient comes out, the management, frequency of the visits to the hospital, or the medication of the patient, and the condition general, the procedures, and the outstanding orders of the patient comes at once on the screen. And when you're managing the patient, you simply enter your details, and they're stored safely, at a storeroom, and the data is protected. And that's really good, in terms of going, the what do you call it, going technological. And then ISBA communication. I talked about ISBA when I was talking of a deteriorating patient. And then what measures do you put in place to prevent your patient falling? I talked about falling. And how do you assess the patient's risk of developing pressure ulcers? I talked about pressure ulcers, but assessing the risk of a patient developing pressure ulcers, I also talked of water loss there. When you look at the age of the patient, the condition of the patient, when you look at the body mass index of the patient, those are the considerations. And generally, the medication the patient is on, if I didn't mention that. So those are the things that you need to consider when you're looking generally the condition of the patient of being at risk of falling. Knowledge and experience relevant to the role. Can you tell me what is your role in the preventing infection in a patient with a surgical wound? I think we talked about that, the IPC. What is your role after a patient falls, both initially and in the coming hours? What will you do? I think we also talked about that in a way. What would you do that the patient falls both initially and in the coming hours? So you need to put some precautionary measures. Make sure that you explain the call bell to the patient so that when the patient is in need of your help, you'll be able to ring the call bell. And also you can have some meds, some meds underneath the bed of the patient. If a patient makes any movement, there will be an alarm from the meds, the force meds. Okay, they're called force meds. Make sure that even when the patient is seated on the chair, you can put a force med there. So each and every time the patient moves, there will be an alarm. Okay, you can, if patients in a tendency of wandering, you put also a wander alarm that will alert that the patient is left the room or is past the position she or he is not supposed to, so that you're able to avoid unnecessary injuries and harm to the patient. Wow, that's as far as the interview tips that I had are concerned. If you have another question, please put it in the comment section box, and I'll gladly respond. And please remember to like, to subscribe, to turn on the notification button for more. As you can see, more and more and more is coming. Yours on the Nurses Forum. Lovers. Bye-bye.